If everyone trained in a relationship-centered model, I would want to believe that, that we really could change medicine. We do know that students who go through this model, everybody says, well, you're trading humanism for rigor. There is that dichotomy that people go to, and they'll say things like, well, I'd rather go to a competent doctor than a caring doctor, as if they're mutually exclusive. So we know these students do really well as physicians moving into the future. We know that some of the factors that lead to flourishing, this more than anyone, have to do with people, relationships, friendships, community, having a sense of meaning and purpose in your work. That's what's going to get you through.
Welcome to Flourishing in Medicine, from Surviving to Thriving. I'm your host, Dr. Mick Krasner, and this podcast is produced by EmPro, a medical professional liability insurance carrier located in New York State. This podcast was developed because of EmPro's deep commitment to supporting physicians, and that includes many other wonderful learning opportunities, and I hope you explore this podcast and other of their offerings. Today, I'm really excited to share with you this conversation with Dr. Liz Gaufberg, a medical educator and associate professor at Harvard Medical School. She directs the professional and academic development at the Cambridge Health Alliance and is a senior consultant to the Association of American Medical Colleges' fundamental role of the arts and humanities in medical education. Her many contributions to innovative medical education all have the goal of keeping the patient at the center while cultivating the skills drawn from both the sciences and the arts into the professional identities of young physicians toward a life of meaning, purpose, and impact. In today's conversation, Dr. Gaufberg reflects on the Cambridge integrated clerkship model as a more holistic approach to medical education, emphasizing relational learning and continuity of care. She discusses the positive impact of this on students' professional development and patient-centeredness, while acknowledging systemic challenges within medicine that require broader systemic changes. This is thoughtful, warm, humble, and it was just a delight to talk with her, and I hope you enjoy our dialogues. And now, the conversation.
It's so great to have you here, Liz, on Flourishing in Medicine, from Surviving to Thriving. Welcome.
It's great to be here, Mick.
Thank you. I'd like to begin this conversation, with the way I look at it, with what I asked most of the guests, which is really tell me a little bit about the origin of your work in medicine. And the kind of way I'm wondering if you could share with us is really, what are some of the influences, the things that happened to you in your education early on, growing up in the milieu that you experienced as a young person, that moved you and inspired you to pursue this?
Well, I would say probably the biggest influence on me in terms of wanting to become a doctor was my stepfather, who came into my life when I was about 13, and he was a physician and loved medicine. And he was such an important person to me. He came kind of at a critical juncture in my life. And he used to say to me, I think you would be a great doctor. He loved medicine. He initially was thinking about being a pediatric cardiologist, and then he was in the Air Force and loved space medicine and finally became a psychiatrist. And so he gave me this sense of all the possibilities that medicine, the doors that it could open for a person. And my mom, well, she expresses her love like a fire hose. And she grew up in a poor family in the Depression. And I remember when I was a kid in the late 60s and 70s, she kind of came into awareness and got involved in consciousness raising groups and really thought about women and their role in families and society. And I remember her saying to me, you should do something in which you won't be dependent on a man, and it should be a well-respected profession. And my mom and my stepfather together really sort of joined forces, and it sort of propelled me into wanting to be a doctor.
I'm always really intrigued, Liz, by phrases and words that kind of just grab me, and then they kind of stay there. I'm still listening to what you're saying, but one was like a fire hose, the way your mother. So, I have lots of thoughts about that. Does that mean, it was just tons of constant, overwhelming information and control, or was it more like she'll give you anything you want, but if you wanted it, you're going to get a lot of it? So I'd like to hear a little bit more about that. But also, you said that your mom had at least brought you the idea that, you need to be able to support yourself. You can't rely on a man. And that could be done in a lot of different ways. You could have become a civil servant working in, you could be a school teacher. You could have done a lot of things that you would have been able to support yourself. So I want to get a little more fill in the story. Maybe it was your stepfather's influence, is why medicine? Because there's a lot of other things you can do to support yourself that aren't as rigorous through the training as medicine.
Yeah, I mean, a fire hose, if you shoot it at somebody, it'll push them into the future. My mom was and is a strong person and has very strong opinions about what the people she cares about should do. And she's very direct. Probably if I could get a copy of my admission essay from medical school, I could give you a very accurate answer about what motivated me to go into medicine. I have no idea where that is, in the basement somewhere. But I probably wrote something along the lines of that formula that a lot of people write about, wanting to combine science and, a desire to help people. And I liked science, I think, in college. I didn't love it. I was more into the humanities. And certainly I wanted to help people. And as you're saying, you could do that in a lot of different ways. But I was interested in stories, I think. I felt that medicine could give me a window into people's lives and worlds that I would never have otherwise. And as I've said to you before, I feel almost guilty saying that because it makes me sound more voyeuristic than altruistic. But over time, when you listen to people's life experiences, certain kind of empathic curiosity grows and grows, and that motivates, I think, really a desire to help. And so I feel very privileged to have patients, and more recently, students and residents open up to me. It's something that gives a lot of meaning to my professional life.
Thank you. We had another guest whom Dr. Rita Charon, speaking about narrative medicine, and I think the way you describe story as being something you're really curious about in the medical context, to have narrative competence is what she calls it, is really central to actually developing that relationship, really understanding empathically and being able to act compassionately out of that understanding of that medical relationship that we have with our patients. So you went into psychiatry. Maybe you can share with us a little bit about psychiatry beyond the model that your stepfather had, but all the choices. You mentioned all the choices that were present in medicine. And then if you could, I'd like to also, because I bet it happened pretty early, I'm wondering, I won't bet on anything, wondering your interest in medical education. I'm assuming it happened early, maybe I'm wrong, but something about your gift and your path and your purpose, your why, has to do with combining your love for story, psychiatry, your profession, as well as education.
So I want to tell you something, Mick. I trained both as an internist first. I did a whole internal medicine residency, and then I went on to psychiatry. And part of the reason I did that is I found myself more interested in people's experience of their illness than I was kind of in what their sodium was doing. And I went on to psychiatry because I wanted that deeper understanding of people, sort of how they made sense of their illness, their lives, their world. But even when people know that I trained in both, they focus on the psychiatry thing, which I think is really interesting. When I'm introduced at parties, I'm introduced as a psychiatrist. So I think that sort of sticks in people's minds, maybe because they feel like I'm analyzing the conversations. I think there was one moment, I recall one moment in my very first month of medical school. It was a moment in anatomy lab, and I think all of us who went through anatomy lab remember sort of this cavernous room with gurneys with bodies covered in plastic tarp, and the smell, I think for me, is one thing that kind of sticks with me. And I recall that I had a group of about 4 partners, and every day we would go in and unwrap the part of the cadaver that we would be assigned to dissect. And we never really found the structures we were looking for until one day we had finished this dissection of the brachial plexus. And, as you know, it's this sort of sheath of nerves that comes out of the cervical spine and kind of across the axilla in a parallel fashion. And it was a beautiful dissection. And other students from the class gathered around the table, and I was looking at this dissection and kind of marveling at it and thinking it was so beautiful and intimate, and nobody had ever seen this part of this person's body. And I also thought, wow, it kind of looks like the strings of a guitar. And I felt a little guilty at that thought. And in the next moment, one of my lab partners took 2 fingers and started kind of plucking or pretending to pluck on the strings of the brachial plexus and singing a little jazz tune like boing, 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 brachial plexus. And the group just burst out into laughter. All but one woman who was at the end of the table, and she looked around with this look of kind of scorn on her face, and she turned on her heel and walked out. She said, "I can't believe you guys," before she walked away. And looking around, the expressions on people's faces after she said that, some people sort of were rolling their eyes like, what's her problem? And some people looked really ashamed. And I don't know, I don't remember what the expression on my face was, but looking around that table, I thought every single person at this table is a good person. The admissions committee did a good job, but you don't put a group of 20-something students in a room filled with dead bodies and without any opportunity to reflect or to express gratitude and expect something other than that to happen. And that was a moment when I said to myself, I need to do something about this. I have no idea what it is, but I need to do something about this. And then I filed that thought away for a number of years. But I always come back to that moment as a certain touchstone. And I think it was the moment that I decided I wanted to get involved in education in some way, particularly some of the cultural and socializing forces in medical education.
Wow, that is so interesting. First of all, anatomy lab can be highly evocative, is highly evocative for most students. And as you know, I've been working on this film, and for our students, equally so. I think it's one of these quote unquote rites of passage, but also just really brings out all sorts of a whole range of emotions and responses and thoughts. So I think for that to happen in your small group is almost like a microcosm of what can happen in any kind of group process, whether it's in the anatomy lab or elsewhere. So I think that's really a wonderful place to become inspired to be a medical educator. You actually have brought the arts or made the arts in some ways a center piece of your focus in medical education. And I'd like to understand maybe a little bit about that. Why? I know that you are involved in the AAMC fundamental role of the Arts and Humanities in Medical Education program, FRAHME program. And maybe you can talk with us, because I think this actually does relate to this podcast very directly, flourishing in medicine. So maybe you can help us, just tell us your story about how that came about, arts, and why. It sounds like it was already there because you saw it. When you saw that brachial plexus, you were in some ways just in awe at the incredible beauty of it, and also the intimacy of sharing that with others. But yeah, please talk to us a little
Sure.
bit about art. Yeah.
So I think it was a natural progression from really being interested in reflection and reflective practice, a topic that I know is really near and dear to your heart. And I was invited early on to lead these small group, reflection series with students and residents. And it was hit or miss, quite frankly. You can come into a room and sit in a circle with a group of trainees and they're exhausted. Food does help, but they're exhausted. And if you start out and say, hey, what are some challenges you've experienced? Or even let's talk about moments of joy. More often than not, they just shut up and are thinking about what they could be doing at home or the exam the next day. And what I found over time was if you could find something that they could respond to, some sort of reflective trigger. And it's always better. I started out bringing my poems in or coming up with arts activities that I thought would be interesting to them. But what I learned is that if the students actually come in with something that's meaningful to them and share it with their peers, often they choose something from the world of the arts. They'll choose a poem or a passage or a song that they've written or means something to them, and they share it. And then they talk about why it's meaningful to them, what role it's had in their lives, their development. And what happens after that is magical. The other students are so respectful in the questions that they ask, and it moves on to sharing maybe more from the person who has shared. They go a little deeper in their own reflections, but it also leads to conversations in the group. And I love those sessions. First of all, it's always relevant to the students, because if somebody brings something in and says, this is meaningful to me, I'm not having to guess about, where they're at in their development or what would be supportive of what they need to consider, but they bring it in. And so they tell me. That led into using the arts and humanities a little bit more intentionally. I think of those objects. There's a phrase called the third thing that was popularized by Parker Palmer. And his sort of way of framing it is that you can start talking about a thing, whether it's an object or a photograph or a poem, and it leads to your own stories and revelations. But if those revelations ever become too personal, too intimate, you can go back to the thing. And so the thing serves a kind of modulating function between depth of revelation and emotional safety, because you never want people to share more than they are comfortable with. And so once I got into third things, and then, you go into a museum and you look around and you say, this is filled. These objects, these paintings, these sculptures, these are third things. And, you can be like a kid in a candy shop. And of course, it's, my focus has become visual art and museum setting. But for me, that kind of opened up a lot of other possibilities. So I had been thinking, okay, the arts are about reflection and renewal. But moving on, I realized that you can use art engagement activities to teach kind of the core skills of doctoring. So what do you need? What sort of competencies do you need to be a good doctor? Well, you need to be a close observer, observation, interpretation, metacognitive reflection on your own biases, teamwork. Medicine and teaching are both improvisational acts. I'm missing some, but what we do in the arts and humanities is we start with some kind of engagement activity, and then we reflect on it. Sometimes we ask a question. My colleague Meg Chisholm coined this question: what did that experience ask of you? And then they talk about what kinds of capacities they needed to engage in that experience, and they translate that to medicine. You could have a conversation around a work of art, around a painting, and you're looking at the same painting, but I see some things and you see other things, Nick, and the third person notices another detail that neither of us noticed. And so we're collaboratively building an interpretation. We're making meaning together. And it's always this wake-up moment when you say, wow, I didn't see that thing that Mick saw, and that really changed things for me. It kind of deepened my understanding. I remember one time I was engaged as a participant in one of these discussions, and I came to an interpretation of that work very quickly. I knew what was going on. I knew what the artist intended. And every time someone pointed something out that contradicted my narrative, I just pushed it away. And every time somebody said something, I zoomed in. That's something that confirmed my narrative. And all of a sudden, I had this insight about anchoring bias. And thought, when do I do this at other times in my life? And when I would start to do that in another context, I would remember not just that experience, but also the work of art. It was like anchored in my brain because I remembered that work. And I do think that connecting insights to images, to metaphors, to things that are emotionally evocative really helps them to stick. Now, you mentioned FRAHME, and I can't let this time go without talking up the AAMC fundamental role of the Arts and Humanities and Medical Education Initiative, partly because it highlights how important this has become in medical education for the AAMC to, I believe it's the third foundational area that they've decided to focus on over the last maybe 15 years. The first was the integration of medicine with the biological sciences and then with the social sciences, and now with the arts and humanities. And for an organization that is so prominent and powerful in medical education to say this is fundamental is really meaningful. And we put out first we started with a scoping review of the literature on arts and humanities interventions across the developmental spectrum, including with interprofessional learners. And then we sort of used that information to begin to explore. We wrote a monograph describing, and this is all on the WMC FRAHME website, describing the state of the field and putting forth recommendations. We had small grants. There's a great digital getting started guide that you can find on the website if you're interested in delving into the arts and humanities, and it's divided up into the ACGME competencies. So we really do try to link these arts and humanities interventions with what you need to know as a physician. It's used to be that what we offered in medical schools were kind of haphazard, elective, and based on faculty's own passions, which is great, but we're really trying to have this be more evidence-based and linked to what you need to equip yourself as a physician.
I'm thinking about, the following. A lot of thoughts swirl because it's really a wonderful and very powerful approach and tool or set of tools. The saying, something like, I'm paraphrasing it, youth is wasted on the young. And in some ways, these aspects of medical education that you're describing, I'm tongue-in-cheek saying they're wasted on the students, because this podcast, really is about flourishing in medicine, and really our listenership predominantly, although we do have students, we've interviewed students, really are people out there practicing. And so I'm thinking that this kind of exercise, this kind of experience could be shared in teams, could be shared in clinical settings, could be shared among colleagues, could become part of our regular ongoing, grand round series, and they probably are. We had Beth Lown here on the podcast talk about some of the things they're doing and how the Schwartz Center and Schwartz Rounds came about, which is a similar kind of thing, is to kind of change the dialogues that go on within the clinical environments so the environments become supportive, fulfilling and supportive, and really help people flourish. So I'm wondering if we could just do a little kind of mental exercise, and you can maybe walk us through what could this look like. Let's say you're doing a little professional development with a group of hospitalists at the Cambridge Health Hospital. You can invite whoever you want and just maybe walk us through what this may look like in a couple minutes. Just talk us through. Because I'd really like the listeners.
Can I bring them to the museum, Mick? Is that okay?
You can do it in a museum, but that's one way of doing it. But I'm thinking, practically to kind of bring this as a true possibility. And it's hard to get a
Yeah,
group of people
yeah.
out of thetheir work environment to go to a museum. What a wonderful thing. But to actually do it when they're in their
So
workspace during
we
their
could
work
use a
times.
poem. We don't usually think about hospital art as an option, but most hospitals have art. It doesn't have to be, great and famous art, just something really to do a close looking exercise with. And
Hmm.
again, we do ask people to try to cultivate a beginner's mind in any of these exercises. And one of the values of the arts and humanities is that if we ask people to do that, no one is an expert. Like the attending doesn't have any more authority about what people see or how they interpret a picture of a person picking flowers in a garden than the ward clerk. And we really emphasize listening to one another, listening to one another's observations, reflections, emotional responses to a work of art. And this process of collaborative meaning making, I think you can do it around any kind of work of art and go as far as you can. The thing about working with the arts and humanities is you're never done, right? We don't move towards closure. There isn't a right answer. And boy, do healthcare professionals want to go for that right answer. So it's about staying in the game and learning more about something, about each other. And then at the end, having to sit with ambiguity, right? We
Hmm.
always say we've learned a lot about, it could be a piece of music. We've learned a lot about this by engaging and discussing, but there's so much more to learn. And some people say, well, I want to read the plaque next to the work of art to find out the right answer. So tolerating ambiguity. And then in that translational piece that I mentioned before, when you reflect on the process and what just happened, people will talk about how everyone had a voice. And sometimes you can get the people that might be sort of considered to be lower on the hierarchy to speak up. And then what happens is when you go back to the clinical setting, some of those lessons may come with you. Some of those people who kind of have more power and authority might say, wait a minute. First of all, I've gotten to know this nurse's aides better as a person, so I might tune in more to what he or she has to say. But they really had some valuable things to say in that setting. So we always think about how what we do, it's fun. It should be fun, but it should be something that leads to more fundamental lessons about medicine. And you bring up teamwork, which I think is really something that's key, because a lot of times we do these exercises in community.
I think the value of having a skilled facilitator like yourself, or someone who has at least some training in leading these things, could be a way of kind of debriefing the group over some of those lessons for people to contemplate. Tolerating uncertainty, as you mentioned, ambiguity, teamwork, communication, psychological safety, all these things, and also, just the biases that we encounter in our work really allow us to begin to address them. We see them show up when we look at the third thing. They're going to show up when we look at the third thing being the patient or a clinical scenario as well. So I think it's a wonderful thought, wonderful idea, and maybe it's time that we think about, bringing this in on a regular basis into our clinical settings. I'd like to just pivot a little bit now, partly in the interest of time, but also partly because I do want you to have a chance to speak about something that I've learned a lot from you about at the Harvard-Cambridge Integrated Clerkship. So, we're both interested in components of professional well-being, especially how medical education, practicing medicine, well-being, professional identity are all connected, and taking a closer look at medical education environment and how that affects flourishing, or the flip side of that, burning out, not just for students and trainees, but as people move into practice. So tell us a little bit about it's more than an experiment because it's actually a living fact, the Harvard Cambridge integrated clerkship, which I think has a lot to teach us about professional identity, about medical education, about practicing medicine, about being prepared to practice medicine, and about taking on the responsibilities of what it means to be a physician.
Sure. As you know, Mick, and we were so happy to host you a couple of months ago at the CIC, Cambridge Integrated Clerkship, that this is an educational model in which a group of students learns the core skills of doctoring by following a panel of patients over time and across venues of care. In our case, it's 12 students out of our entire medical school class of, I think, around 160. They don't do the traditional block rotations, but they learn medicine through these close longitudinal relationships with their patients, with their peers, with their faculty mentors, and with the community that is the hospital. I remember when we started back in 2003 to 2004, we spent a planning year under the leadership of doctors David Hirsch and Barbara Boger. And we started with what are the principles we want to breathe life into in this model? It was such a luxury. And it was the only time in my entire career, maybe my entire life, where we started with these foundational principles and then we built from that rather than trying to fit our curricular aims into kind of pre-existing formats. And so some of the principles that we identified that we wanted to give life to were things like, students should have a meaningful role in patient care, and that learning should be relational and developmental and also rooted in the learning sciences, and that we should be preparing students to take care of patients in 21st century medicine, which looks very different from medicine at the time that block rotations were established, when patients stayed much longer in the hospitals and families came and surrounded them. It's much more ambulatory now. It's much more chronic disease focused. And boy, do we need relationships and humanism more than ever. And I can tell you, I think this is our 22nd year. Whenever we run into a rough patch in the curriculum, we actually go back to those principles and say, are we living them? And what can we do to get closer to them? And sometimes we can do better than other times, but those are real anchors and touchstones. We actually did a couple of studies on the clerkship to evaluate it. The first 3 years of the clerkship were a pilot, and the dean at that time said, you have to show that these students do the same or better than sort of traditionally trained Harvard Medical School students if you want to continue. Things like on those traditional measures like the OSCEs and the shelf exams, and our students did. But I could tell you a little bit about some of the studies we did that were really sort of powerful and validating. We designed these studies as an intervention with a control group. And it was a pretty good control group of students who were trained in traditional block rotations. And most of them had wanted to come to the clerkship, the integrated clerkship. We had more students than we could take, and so it was a lottery. So these were students who were sort of predisposed to this model, and they didn't look any different on any measure we could come up with than the clerkship students. So they started out very similarly or indistinguishable, and we did a lot of measures to start with. One of them was a scale called the Patient Practitioner Orientation Scale, which was kind of a measure of both caring and sort of sharing decision-making with patients. And at the beginning, before the clerkship year, the control group and the CIC students looked exactly the same. And at the end of the year, the control group had lost ground on patient-centeredness. And we know that many studies have shown that over the clinical year, students do tend to lose ground in empathy and patient-centeredness. But our students gained ground in that domain. And okay, so they're in this model that's known to be focused on humanism and empathy and relationships, and they gain ground. Not too surprising. But we resurveyed them after 4 to 6 years. It was 3 cohorts, so it was 4 to 6 years after they had graduated. And it was like railroad tracks. Our students retained the greater patient-centeredness that they ended the year with. And the other group stayed at their level. And there are a lot of hypotheses about why that happened, but it seemed like there was some kind of an immunizing effect that helped them get through some of the challenges, perhaps, that came in the future in residency, some of the kind of dehumanizing experiences that sometimes people have, and that maybe our students were able to get through that and hold on to that patient-centered ethos that they learned over a year in the clerkship. At least that's what we want to and do believe. We also did semi-structured interviews with that same group of the first 3 cohorts and did a study on professional identity formation. We really wanted to see how, looking back, they viewed the contributions of the clerkship to their own professional identity formation. And some of the things that they talked about were our encouragement for them to integrate their pre-professional identities with their emerging professional identity. We really cared about who they were as people and what they brought with them. We don't want robot doctors. We want doctors who express their unique selves, their values, their backgrounds, their identities in the physician role within physician kind of professional boundaries. But that integration of pre-professional and professional was important to them. Learning through caring relationships, they remembered medicine because it was linked to a patient that they cared about. It was linked to Florence. It was linked to Mr. Smith. And they remembered that person. And so they remembered about diabetes or hypertension or depression. They appreciated the ability to discover meaningful roles and responsibilities in patient care. They appreciated support for their own autonomy and learning. And they said that they appreciated both a curriculum and an institutional culture that made values explicit. This is what we care about. We're not always perfect. Sometimes there's a gap between what we say we care about and what we do, but at least we're always striving. And, I think that may have something to do with this institution now called Cambridge Health Alliance that I've been with for 34 years. And part of the reason that I and many others chose it was because of the mission, that it's a public hospital, patient care mission, community health mission. And I'm biased when I talk about my institution, but I do think we really do try to live our values. There's one other thing I'll say, because I don't want to sound like completely blowing our horn. There were real challenges, and sometimes the things that are good about something, if you have them in excess, they backfire. So there were really 3 things that we talked about and we discovered. One was some challenges with professional boundaries, sort of common boundary challenges like self-disclosure or social interactions with patients or gifts. Another had to do with health advocacy, because the students that came to us really were oriented towards advocacy. The third one was, boundaries, advocacy. Oh, and negotiating their own learning agenda could be overwhelming at times. And to go back, the first one, boundary challenges, if you put a group of save the world students into this environment where they're making relationships with patients, of course, your patient is going to say, you are going to come to my kid's 2nd birthday party, aren't you? Or I remember this one Asian American student who said an older patient from her culture kept wanting to fix her up with, the son of this patient, or gifts that sometimes felt, we have a lot of poor patients, immigrant patients, or gifts that felt either too personal or maybe more expensive than the person could afford, or being given perhaps in the hopes of receiving better care, which is true for a lot of these patients from countries where that was expected. So how do you navigate? How do you show gratitude, say for a gift, but also sort of setting appropriate limits? It can be a lot easier to relax limits once you have to establish kind of establish those boundaries, then to kind of backpedal up a slippery slope.
Sure.
So working on those boundaries, and the key to that is putting the patient at the center. Like, what is in the best interest of the patient? Is it in the best interest of the patient to tell the patient that I've also had colon cancer and it was really hard, or I found this useful? Or is that going to make the patient feel like, the doctor thinks they understand, but they really can't know their experience, or that the doctor is talking about themselves because
Right.
they think they're the most interesting person in the room? Or so getting the students to think about that, and also getting them to forgive themselves if they said something that they felt, they should have said differently. The advocacy thing, I think, is really, really key, because it's become a really big thing in medical education. We have curricula now on health advocacy. We encourage students in activism. And I think there's a real kind of discussion that needs to be had, and maybe it's happening in some places, about kind of what's the telos of medicine. Is it about one-on-one care for that patient right in front of you? Is it about social justice? Is it about public health? And we would find with our students, they focused a lot on social determinants of health, which is really important. But how much? We had one student who his patient was not showing up for their appointments. That was affecting their health status. So this student went out to the patient's home and figured out that they weren't coming in because they had to take 3 bus routes. They didn't speak English. They were new in the country. So the student went with them and took the 3 buses and explained how to get to the hospital. And that took hours. And are those useful hours for a medical student? Or should they be studying? Or should they be, sort of scrubbing in on, the surgery that their surgery preceptor wants them to scrub in on? So that, those tensions were there. I mentioned the surgery preceptor, and if you're on a block, a block rotation, if you're in that model, you kind of you're in one discipline, and you're sort of, I don't want to say told what to do, but it's, you come in and you pre-round, then you round, and maybe there's a noon conference, and that you're accountable to that service. Our students have preceptors in all the major disciplines who all are incredibly passionate about them loving their specialty and engaging with the patients that they share with the students. So if you have your medicine preceptor say to you, you have to come at 10 a.m. because that homeless patient that we haven't been able to get into the clinic is going to be here. And then you have your surgery preceptor saying, you have to come and scrub in on that surgery. How do you articulate? First of all, how do you figure out how to prioritize your own learning? But how do you articulate your learning priorities in a respectful way to people who are above you in the hierarchy? And at times that's just so overwhelming to the students. But when they're done, they've learned real life skills.
It's sort of a hypothetical question because, most people study this and most experts would agree that challenges in medicine, whether people flourish or become burnout, really have to do more with systemic factors and the culture of medicine than individual deficiencies or individual factors. So I'm wondering hypothetically, and I know that you've shared with me that, this model of education has found its way into many, many, many medical schools. It still is not by far the dominant model of the clinical experience for our medical students. How would the culture of medicine change if a majority of medical students were trained in their clinical experience, their formative clinical experience in medical school in this fashion? Just kind of riff a little bit about what you think that may mean for the culture of medicine, for the systemic factors that really are implicated in the challenges now.
Yeah, so I will mention that over 40% of medical schools in the United States have an LIC. In most of them, it's a very small cohort within a larger class, because the scalability is really hard. And in most of these places, when you've studied these LICs, the students do come out stronger on the humanistic measures. And I like to believe that when people are trained in that way to hold on to keep their hearts open, basically, to be kind, to understand that there's something underneath somebody's perhaps frustrated or, demeanor, and to be a little more gentle about that actually permeates the culture around them. If you turn to someone else, somebody sitting at the nurse's station with you, you notice they're a little out of sorts, and you just say a kind word or ask how they're doing, that's something that kind of is hopefully passed on. So if everyone trained in a relationship-centered model, I would want to believe that, that we really could change medicine. We do know that students who go through this model, I mean, everybody says, well, you're trading humanism for rigor. There is that dichotomy that people go to, and they'll say things like, well, I'd rather go to a competent doctor than a caring doctor, as if they're mutually exclusive. So we know these students do really well as physicians moving into the future. We know that some of the factors that lead to flourishing, this more than anyone, have to do with, people, relationships, friendships, community, having a sense of meaning and purpose in your work. That's what's going to get you through. And those are some of the real sort of fundamental elements of a clerkship like this. And we didn't talk a lot about professional identity formation, but becoming a physician is really a process of socialization. I mean, that David Foster Wallace graduation speech called "What is Water?", where you have these two young fish swimming along, and they pass an older fish who says, "Morning, boys, how's the water?" And the two fish keep swimming along, and one turns to the other and says, "What the hell is water?" And, it's because the culture of academic medicine is our water. It's the one in which we swim, and we don't see it. It's all around us. It's like the other aquatic metaphor is the frog in the boiling pot. Like if you throw a frog into boiling water, he's going to jump out. But if you put him into cold water and slowly turn up the heat, that frog is going to not do well. So it's really the culture, and our students learn pretty quickly sort of, they're oriented to doing well. They want to get into good residency, so they learn what's valued, and it's all in an evaluative context. So if you're on, a block rotation, we have, students that tell us it's much more about how they fit in, how they learn the customs and rituals of that particular service. Do they laugh at the attending's jokes? They feel that goes more into their evaluation than how they did on medical knowledge and skills. So we have to make what we value, what our role models and mentors model. We have to pay more attention to that, because that's what our learners are going to emulate over time.
Agreed. Yeah, we had one podcast already on a model in Switzerland, Raphael Bonvin. I don't know if you know him, but he sort of upended this medical school, completely formative assessment based model, no summative assessments at all learning plan oriented with a lot of the humanism built in. And it's really remarkable what's the effects of that, at least on that education. So as we come to the close, Liz, I just wanted to give you a chance to share with us. I think our listeners would like to know what it is you like to do to take care of yourself. You obviously must love this education piece and the arts and all that, so that's probably part of it. But what else rounds out your life to give you that energy and inspiration and vigor and optimism, which we see by just talking with you?
So I love being with my family. My husband, Slava, who's a physician and a musician, and I have 4 grown-up daughters. I can't believe they're grown up, but they're in their mid to late 20s now. 2 of them actually are in medicine. One just started a residency in pediatrics, and the other one is a 4th-year medical student who's also decided to go into pediatrics. And of course, my mom is already planning out how they're going to practice together. But I love, they're just wonderful girls. And my husband and I love being with them. They're all musical. They got their musical talent from him. And so, it's just such a pleasure to be with them when they, harmonize and play music together. I get to live in the most beautiful place in the world. It's a place called Squam Lake in New Hampshire. I live in the woods, on the lake, in the mountains, and that's incredibly grounding for me. I love walking in the woods. I try to do it every day. I try not to listen to podcasts, although maybe I'll make an exception for yours. I really try to be present, on those walks in nature. I am at a stage in life. I used to be, and still am, very social. I always wanted to meet more people. I had that interest and still have in stories, but I find that I really want to prioritize relationships with people who, I'm already connected with, who fill my cup, and kind of go a little deeper into those relationships than spread more laterally with new people. And I want to say that a lot of the deep friendships that I have are people who I've met through the worlds that you and I inhabit, through organizations like the Gold Foundation, or you mentioned the Schwartz Center or the Kern National Network, Harvard Macy Institute. But the people that we get to work with are like the coolest people in the world. People who are interested in stories, people who want to care for other human beings. They're fun, they're funny. And so community, I think I've mentioned a lot of the experiences that do lead to flourishing. And I'm very, very lucky and privileged to have the life that I do, and to know people like you, Mick.
Well, it's very fortuitous for me to know you, Liz, and thank you so much again for sharing your time and your thoughts. And I love that you shared all those organizations, because we'll put those in the show notes. Those are great resources for our listeners. So thanks again.
Thank you so much for listening. I'll include a summary of today's podcast and links about Dr. Gaufberg and other references that were discussed in the show notes. I'd like to conclude by sharing another practical exercise, actually 2 exercises that I hope will help you flourish. I'd like to draw upon 2 things that came out in this conversation with Dr. Gaufberg. The first, we could call this moments of joy, wonder, or beauty practice. During the next several weeks, choose perhaps one day per week where you'll take a moment to reflect on that day, perhaps at the end of the day before leaving the office, or in your car before walking into your home. And recall, if you can, one moment, one item, one object of beauty, wonder, joy, or surprise. Take note of it. How did it make you feel? How are you feeling reflecting on it? And if you'd like, increase this activity to twice weekly or more as tolerated, even making it a regular habit if you find it helpful. The second practice is a deep looking or observing practice. At home or at work or in a public building or other space, there may certainly be paintings or photographs hung. One time in the next week, simply take the time to stop for 5 minutes in front of one of these paintings or photographs or objects, even if it's something very familiar to you, such as one that has been in your living room for years. Simply observe. Walk around looking at it from different angles and perspectives. Notice the layers of observing. If you are seeing things that you have not seen previously, or asking yourself questions about the image that you've not thought of previously, notice what you observe, what you interpret, and how it makes you feel. This is also a practice you can engage in from time to time as well. Well, I hope you found this podcast and this simple exercise, these simple 2 exercises, useful, and I look forward to having you join us for the next episode of Flourishing in Medicine, from Surviving to Thriving. If you'd like to learn more about EmPro, please visit www.myempro.com or their peer support programs at www.myempro.com/peer-support. If you're a physician or medical student and you need urgent support, please consider calling the Physician Support Line at 1-888-409-0141 or visit www.physiciansupportline.com. This support line provides a safe space to discuss immediate life stressors with colleagues who are uniquely trained in mental wellness and have similar shared experiences of the profession of medicine. And for more information about me and my work, feel free to visit www.mickkrasnermd.com or www.mindfulpracticeinmedicine.com. Until next time.